Good afternoon, everyone, and welcome to the 39th North American Cystic Fibrosis Conference. It's so wonderful to see everyone here, the world's CF science and care community gathered together. Every year I'm struck by the powerful energy and the sense of purpose that fills this meeting. We have more than 4,000 people from 40 countries around the world here with us in Seattle, and about a quarter of you are here for the first time. We also have a large number of people joining us online. I just want to say welcome, welcome, welcome. We're looking forward to sharing together the latest in CF science and care across more than 200 sessions at this meeting. But first, let's take a moment to step back and reflect together on how far we've come and the journey ahead. You know, there's nothing quite like the CF community. From professionals across a wide range of expertise, to people living with CF and their loved ones, to our wonderful volunteers and supporters. Together, we have achieved remarkable progress in transforming CF. Your dedication to defeating this disease continues to change lives every single day. Thank you, thank you, thank you. I want to give a special thank you to our honorary NACF co-chairs as well, and that's Dr. Isabel Surmay-Gadalis and Pradeep Singh. Thank you both for years of dedication to making a difference in the lives of people with CF. If we could you could join me in honoring them. You know, today we can all feel the changes that are occurring in every aspect of CF. We're transforming a disease right before our eyes, and so many of these changes are worth celebrating. People with CF are living longer than ever, with median predicted survival in the US for those born with CF today now over 65 years of age. More than 60% of people with CF are adults and are finishing school, they're starting families, they're building careers, they're living full lives. We're treating CF at the earliest ages of life in an effort to prevent many of the classic signs and symptoms of CF, and now sometimes even treating before birth, right? At the same time, we know that our community still confronts major challenges. We need to make sure that everyone with CF has transformative therapy. We need to keep pushing forward in genetic therapies, our best hope for a true cure. We need to tailor CF care and care teams to meet the evolving needs of people with CF. And we must do all of this while forcefully advocating for access to care and for biomedical science, even as economic and social pressures mount in the US and around the globe. So yes, this is a time of transformation in every aspect of CF. And that means it's also a time to transform our approaches. The good news, this community knows how to rise up and lead. And when it's hardest, we look forward and we innovate. And NACFC has always been a cornerstone of that transformation, where ideas become progress and collaboration becomes impact. So what are we going to focus on during this year's meeting? We're going to start with today's plenary session. We're focused on getting the maximum effect and maximum benefit from CFTR modulators. We'll look at what we've learned so far, what challenges remain, and how we can build even better modulators in the future. Over the next few days, we'll also explore the exciting advances and persistent challenges in developing genetic therapies that can work for everyone with CF. Now, tomorrow's plenary, we're going to focus on what it means to grow older with CF and how we can develop proactive, personalized care strategies for an adult population with varied and changing needs. And on Saturday, we'll turn our attention to health across the global CF landscape and how we can work towards a future in which high-quality CF care reaches everyone, everywhere. At the CF Foundation, we've been thinking deeply about this same theme of transformation as we prepare to launch our next 5-year strategic plan in January. I know so many of you in this room have contributed to our planning, and I want to thank you for that. As we look forward across the program areas that we call Cure, Care, and Community, we're identifying key priorities to ensure that we make meaningful impact now, while also maintaining the resources we need over time to reach our goal of curing CF. We've been very intentional as we've planned in our strategy, our structure, and our spending. In Cure, we're investing in helping to solve key challenges in genetic therapies. At the same time, we continue to advance the next generation of CFTR modulators and support progress on complications in CF. In care, we're reimagining CF Care Network, making sure it's equipped to deliver essential, high-quality care tailored to the needs of a changing population in a rapidly changing healthcare environment. And in community, we're focused on how to best help people with CF navigate life with this disease while advocating for research, care, and support, and doing the fundraising necessary to sustain essential progress. We're deeply grateful to partner with all of you to make a difference in so many lives. I've noted earlier that the CF community rises to challenges, and we've proven that again and again. And we're going to need that same spirit now as we adapt to meet the challenges of today and build the CF community of tomorrow, defined by continual groundbreaking research, top quality care, and unwavering community commitment. And we know that all starts with NACFC. So let's get down to business. Let's commit to using these next few days to continue this amazing transformation together. It's now my honor to welcome the chair of the CF Foundation's Board of Trustees, Casey White. As the first person living with CF to serve as chair of our board, Casey brings strategic perspective and lived experience to our most important decisions. She reminds us every single day why our mission matters and urges us forward. So please join me in welcoming Casey.
Thank you, Mike, and welcome, everyone. Wow. This is a room full of people who create the extraordinary every day. It is truly awesome. It's an honor to be here among so many whose dedication and insight and compassion are changing the lives of people with CF. I recently had the opportunity to visit the CF Foundation's Therapeutics Lab. There, I was shown images of airway cells taken through a confocal microscope. They were vivid, colorful, and stunning. To me, they looked like art, but for the scientists, they tell a story of progress. The first image captures the diversity of cells that work together to keep our airways clear. The next image shows CFTR protein in healthy cells. This image is our goalpost, illustrating what we are striving for, putting CFTR back where it should be in the CF airway. And this last image demonstrates our ability to see CFTR restoration through cutting-edge delivery systems, including viral vectors and lipid nanoparticles. Together, these images trace the evolution of knowledge, each a moment of deeper understanding, leading us forward one step closer to a cure. Aren't these images incredible? And it's just one example of the extraordinary work that this community does every day. You are awe-inspiring. Awe is the feeling of being in the presence of something that transcends our current understanding of the world. Awe is the bridge between science and wonder. I want to give you 3 ways that we experience awe in the CF community. First, awe is vast. It's the feeling we get when we stand before something greater than ourselves, like seeing the hidden beauty of life magnified beneath a microscope. It reminds us about how much there is still to learn and how extraordinary it is that we get to witness it. Awe is also moral beauty. We experience this when we see courage and compassion and dedication in action in the care teams who show up every day for people with CF, and in the researchers who keep asking questions even when the answers are hard to find. As someone whose life has been shaped by this work, I can tell you that this kind of beauty moves us and sustains our hope. And awe is collective effervescence. It's the electricity that fills the air when a community like this gathers, here in this room and online. Scientists, clinicians, families, and people with CF, all aligned in purpose, all moving towards progress. It's the energy that reminds us that we are part of something larger, and that together we can achieve what once seemed impossible. And awe matters. It expands our perspective, and it strengthens our connection to one another. Studies show that experiencing awe increases curiosity, generosity, and well-being. But beyond the data, awe matters because it reconnects us to why we do this work, to the sense of wonder and purpose that brought us each year. So as you move throughout this conference and in the work you do each day, I invite you to notice awe. Notice the vastness of what we're learning, the moral beauty in how we care, and the collective effervescence that makes this progress possible. Because awe isn't just what we feel when we witness something extraordinary. It happens when we create it together. You are creating it every day. Thank you for all you do on behalf of people with CF. We are so very grateful.
Well, thank you, Casey, and we do look forward to an awe-inspiring few days ahead. I'm now pleased to turn the program over to Dr. Stephen Rowe, our Executive Vice President and Chief Scientific Officer at the CF Foundation. Steve oversees the Foundation's Science and Innovation team, which spans the scientific pipeline from basic and translational research through clinical trials, including the Foundation's own lab, as well as our biotech and pharmaceutical collaborations known as Mission Ventures. Steve has more than 2 decades of experience working in CF, including research and clinical care, and we are so very grateful for his leadership. Please join me in welcoming Steve.
Well, thank you, Mike, and welcome, everyone. It's truly wonderful to be here with all of you today. Modulators have changed the game for many people living with CF, and you will hear about that in remarkable progress in today's plenary. But we have important work to do. We are now entering the next era of the research for transformative therapies for all. Our task is urgent and the challenge is formidable, but the road ahead is more clear than ever and deeply inspiring. Today, while CF is duly featured as a remarkable success story, many people cannot benefit from modulators, including about 10 to 15% of people with CF in the United States, with greater numbers in other countries. Some are ineligible because of their mutations. Others cannot tolerate them due to side effects. We also know access to medication, although gradually improving in some places, is a challenge for many. For those who cannot benefit from modulators, there is still no treatment for the underlying cause of their disease. And while genetic therapies may one day benefit anyone with CF, those without transformative therapy are our most urgent priority. The progress in genetic therapies for some diseases has been nothing short of remarkable. They have already changed the lives of certain people with sickle cell disease and spinal muscular atrophy, as well as other genetic diseases. And we are excited that several clinical trials are now underway in CF, testing approaches from mRNA and next-generation gene addition therapies that have the potential to help everyone, to antisense oligonucleotides, or ASOs, designed for specific mutations. Additional work is also ongoing in gene editing, taking advantage of the remarkable progress in other diseases. While these genetic approaches presently remain in the lab for CF, they continue to advance and will eventually form the basis of a cure. Nevertheless, developing genetic therapies for CF poses unique challenges. Delivery remains our most difficult problem, as we need to solve how to overcome the body's natural defenses and also deliver genetic therapy to the right cells. Not every attempt will succeed, And in fact, we expect some will fail. But every step forward, even when difficult, advances our understanding and builds the foundation for ultimate success. We have been here before. Although it may seem that modulators arrived quickly, their development was the result of more than 20 years of basic, translational, and clinical research. In fact, Aurora Biosciences, the precursor to Vertex, was not the first company to attempt to develop modulators. Early on, academic researchers posed new ideas on how to correct the CFTR protein. Some proved correct, and others did not, but all provided learnings, stepping stones to the goal. Ultimately, it took 2 decades of repeated attempts, persistence, and a strong foundation of science before achieving success. As a recognition of this remarkable challenge, the Lasker-DeBakey Medical Research Award, sometimes mentioned as the US version of the Nobel Prize, was just awarded last month to Drs. Michael Welsh from the University of Iowa, Jesus Gonzalez and Paul Negulescu, each from Vertex Pharmaceuticals, for the research into the CFTR protein and pharmaceutical discovery that laid the foundation for the development of CFTR modulators. This history should give us confidence. The CF Foundation and our research community have a track record of taking bold risks and succeeding even against the odds. We are driving this next frontier of science, working with you to position CF research to take advantage of breakthroughs that will one day lead to transformative therapies for every person with CF, no matter their mutations. Research toward genetic cure for CF is more complex and costly than anything we've done before. We must be smart and bold, pursuing the most promising science, pivoting swiftly when our ideas do not work as expected, and building on learnings from every result. This past year has marked significant scientific progress, with further refinement of mRNA and RNA-based approaches bringing us closer to transformative therapies. Gene addition therapies continue to advance as the latest evolution of our attempts to restore CFTR protein expression to the lungs. The Foundation's investments in gene editing technologies have also increased, given their promise to lead to curative therapy for CF, with up to $40 million in total directed towards prime medicines, which is using a pioneering approach that precisely edits a variety of mutations and which has already begun to proven in the clinic in other diseases. As you can read from these headlines, we also continue to support a variety of programs to address complications, with a particular emphasis on meeting the evolving needs of people with CF in the new modulator era. It will be critical that we continue to advance research priorities while enabling that resources remain available to achieve our ultimate goal of curing CF. To make sure we have the financial and scientific means to go the distance, we must focus our resources on the areas that are of research that can have the greatest impact. Coming from academia, I know firsthand that to be successful, academic research will play a critical role. Academic scientists not only deepen our fundamental understanding of the disease, they are also critical to posing unique and creative solutions to the challenges of developing therapies and taking on questions that are presently limiting progress. Committed researchers are also critically important to addressing the latest questions important to the CF community, but that industry is unlikely to pursue. Areas like gastrointestinal issues, diabetes, and aging with CF. To meet both current and future needs, we have developed a clear scientific strategy. Over the next 5 years, this strategy will center on 2 goals. First, we will continue to prioritize transformative genetic pulmonary therapies, approaches that can improve lung function in the near term while never losing sight of our ultimate goal of a permanent genetic cure. Second, we will concentrate our efforts on areas where the role is most critical, where the need is high and the burden is significant and our ability to influence scientific progress is strong. This also means we must be thoughtful about how we support academic research. For projects aligned with our strategy, we will continue to be bold, creating room to take risks and accelerate the science. And for projects outside of that core focus, there will always be space at the CF Foundation for truly outstanding, innovative ideas. Academic investigators have always been at the heart of CF progress, and that will not change. With the concept of high-throughput screening for CFTR modulators was devised, it was certainly not mainstream. We are strategically using our resources, scientific, clinical, and financial, to meet today's needs while ensuring long-term success. And because we are working in one of the most fastest moving areas of medicine, we must also remain nimble, adjusting our focus to keep pace with new opportunities and discoveries. I encourage you to join us at the upcoming session of our academic research strategy on Saturday. We will share more about our areas of focus and the opportunities ahead as we prepare more comprehensive communications to follow. This community, all of you, will play a pivotal role in developing a cure for CF. Without you, there are no new ideas. Without ideas, there are no trials. And without trials, there are no transformative therapies. We have always been defined by our collaboration and persistence, and together we will continue to chart the course towards the future of CF. It's now my pleasure to introduce two extraordinary leaders in the field of CF who will explore the impact of CFTR modulators on the disease, discussing both achievements and ongoing challenges, as well as new therapeutic approaches with the potential to continue to transform the lives of people with CF. Dr. Claire Keating has a long-standing commitment to cystic fibrosis care and research, dedicating her career to the treatment of adults with CF and research into new treatments of the disease. She brings deep clinical and research expertise, serving as co-director of the Gunnar Esiason Adult Cystic Fibrosis and Lung Center and the Therapeutics Development Center at Columbia University Medical Center. Dr. Keating has been a leader in clinical trials ranging from early phase studies to large multi-center efforts, including serving as the national principal investigator on several pivotal trials, including the CFTR modulator vanzacaftor. Joining her is Professor Marcus Small, Chair of the Pediatric Research Medicine and Director of the Christine Herzog Cystic Fibrosis Center at Charité University Medical Center in Berlin. A pediatric pulmonologist and physician scientist, Dr. Small is also one of the founding directors of the German Center for Lung Research and the German Center for Child and Adolescent Health. His groundbreaking research integrates basic and clinical science to uncover the mechanisms of CF and move mucus-obstructive lung diseases and translate discoveries into new therapies. Please join me to the stage in welcoming Dr. Claire Keating.
Good evening. It is really my great pleasure and privilege to be with you here today to speak about the impact of modulators on cystic fibrosis. Now, before 2012, not a single individual with CF had any therapy available to target the molecular cause of their disease. And now we're approaching 6 years of experience with highly effective modulators for a majority of the CF population. I'm going to review this experience, and later in this talk, Dr. Small will discuss more advancing therapeutics and research as this field continues to move forward. Here is my disclaimer and my disclosure. Okay. Now, cystic fibrosis affects the entire body. And while the impact and damage to the lungs that it causes is the primary focus for clinicians and researchers, we know that it is a multi-system disease and can cause significant symptoms and complications over a lifetime in all of these organ systems. Today, I'll review not only the impact of modulator therapy on lung health, but also how it helps or falls short in managing complications in other organ systems such as liver, pancreas, intestines, and the reproductive tract. But let's take a step back. The commonly used sweat chloride tests is a measurement of the extent of chloride ion channel dysfunction or cystic fibrosis transmembrane regulator dysfunction in CF. Here in the upper left corner are people with severe CF with genotypes F508del 2 copies or F508del minimal function, with very high sweat chloride levels and very low levels of chloride ion transport. And in the lower right, we see people with 1 copy of CF mutation, carriers, who are generally healthy, or people with no CF mutations, and they have normal or near normal chloride transport. Restoring the CFTR function positively impacts lung function. Looking here on the right, with continued development of increasingly effective modulator therapy, we see improvements in lung function, as measured by FEV1% predicted, which brings us to where we are today, with the highly effective modulator, elexacaftor, tezacaftor, ivacaftor, restoring CFTR activity over 50% and higher, and restoring lung function upwards of 15% predicted FEV1 in F508del. From pooled clinical trial data, we also see a relationship with reducing sweat chloride levels on therapy. It correlates with ever-improving lung function. Here on the left, you see rising FEV1 with lower sweat chloride levels achieved, with some plateauing as we approach 30 millimoles per liter. And a similarly important outcome of exacerbation rate, we also see decreased annual rate of pulmonary exacerbations with lower sweat chloride levels achieved on therapy. So the use of highly effective modulators is ever increasing in the US with expanding approvals. Now we have elexacaftor, tezacaftor, ivacaftor, commercially known as Trikafta, and to which I'll predominantly be referring to as ETI for the duration of this talk, and the recently approved vanzacaftor, tezacaftor, deutivacaftor, commercially known as Aliftrek, to which I'll be referring to as VTD for this talk. We now have therapy for 303 cystic fibrosis mutations. The CF patient registry shows here on the right, in the red bars, the ever-increasing use, with 20% of ETI use in 2019 at first approval, increasing to 76% in 2024. However, not an insubstantial amount of this population is ineligible for CF mutations by genotype, represented by the dark blue at the top of the bar. In addition, this orange section represents those eligible for CFTR therapy but are not taking it. And this can be for a variety of reasons, but certainly includes those who do not tolerate therapy or for those who it may not work as well. So let's take a moment to hear from Sydney, an adult with CF, and hear about her experience with CF therapy.
I'm Sydney, I'm 22 years old and I have cystic fibrosis. So in August, I moved out into the Pittsburgh area for a new teaching position after graduating from college in May, and I am a 6th grade learning support teacher. In 2019, I was first prescribed to be on Trikafta, and that was going into my senior year of high school. And then more recently in June, I was prescribed to be on Aliftrek. Before Trikafta, high school was definitely super tough for me. I was in and out of the hospital a lot, dealing with a lot of infections. My lung function had decreased down into the 60s, and just getting out of bed daily was super hard. So the most thing that I've noticed right after being on Trikafta was being able to jump back into soccer, being able to go out and do things with my friends, and just going out and living life, because everything was put on a hold whenever I was super sick. After my freshman year of college, I was getting super sick, and I wasn't sure because my body was super worn down after just being in school, playing soccer, and living as much as a regular life for a college student, or it was because the medication wasn't working. But we saw a big decrease in my pulmonary function test, so we just started to figure out, weighing the options, is it better for me to stay on it or to go off of it? And we decided just to stay on it, because at that point there was no other medication. We were going to take every bit that it was giving me still. I ended up missing almost my entire senior year of soccer, being in the hospital, being super sick. My final goal was to make it out for the last game of the season, and with the support of my doctor, they got me home on IVs. My coach helped me surprise my team.
Our last senior is number 26, Sydney Willig.
They were there supporting me for day one, so I wanted to be there to support them in whatever way possible. So I went in for the last 10 minutes and was able to finish up on the field with the girls that I've been with since day one. That was just really important to me, to be able to finish on my own terms and not have CF finish it for me. In 2024, in December, I was in the hospital for 5 lung infections. It started off with me going in just to get a normal scope, finding out about the infections, and then from the scope I also got a collapsed lung. And going through my mind at that point was, am I going to be able to graduate on time? Am I going to be able to go into student teaching? And we started looking ahead to see what else could be the next answer for us. Finding out that Aliftrek was coming out, I was super excited, and we are looking forward to a new medication. Having the different modulators allows varieties of medication to go out to reach more patients, which is really important, and allow them to get the benefits from it. For me, having a lift track get approved was really important. My personal experience was being able to see my daily life change, going from barely being able to walk to running 10 miles to running my first half marathon in May of 2025. It changed so quickly and I just felt so much better. The modulators, I've always been told growing up that it's not a cure, and I always keep that in the back of my mind. It's just a Band-Aid to help us to find a cure, and I'm so thankful that we are finding these Band-Aids to hold us over for as long as we can to help us. It's just changed my life for so many good things that I'm excited to see what else of a normal life that I can live having CF.
We thank Sydney for sharing her story. She certainly reminds us that not every person's journey with CF is the same. So clinical experience and clinical trial experience with modulators, for most, continues to deliver on efficacy and safety, though we certainly know that individual responses are possible. We have experience with ivacaftor now for over 10 years, and it is approved for use to start at age 1 month. ETI therapy is approved to start at age 2 years. With open label extension data from clinical trials, we see in school-age children, age 6 to 11, there is stabilization of lung function. And 100% of children with F508del homozygous genotype have sweat chloride levels less than 60 millimoles per liter, below diagnostic range. And in the group with the most experience with ETI, ages 12 and up, we also see stabilization of lung function over years of use and even lower rates of pulmonary exacerbations after 152 weeks of use. And now we have VTD, or vanzacaftor, tezacaftor, deutivacaftor, available as an alternate therapy just over this past year. But let's look beyond the clinical trial data. What are the benefits to the pulmonary system besides the standard outcome measurements of lung function and exacerbation rate in clinical trials? And how does it benefit or not other organ systems? There have been many efforts globally to try to answer the question of real-world use experience with ETI. And all these studies are a credit not only to the hard work of the investigators, but also to the willingness and enthusiasm of the CF community to participate. And for this, we are very grateful. Researchers in the US, the UK, and Germany looked at alternate measures of benefits of modulators on lung health, specifically lung clearance index and lung imaging of MRI and CT scans. Lung clearance index, or LCI, is another measurement of pulmonary function, which is much more sensitive to detect early CF lung disease. Here on the left, investigators recruited participants ages 12 and up to perform LCI before and 8 to 16 weeks after ETI use. And we see almost a uniform lowering of LCI score. And a lower LCI score means better ventilation throughout the airways. To the right is MRI imaging of children with CF before and 3 months after use of ETI. And while it may be subtle to see, and these red circles and the arrows show areas of consolidated lung and areas of mucus plugging, which resolve on follow-up MRI cross-section. And to the right is perfusion imaging, showing decreased blood flow to a consolidated area of the lung due to infection and inflammation, which on repeat imaging shows much more homogeneous perfusion. The impact of ETI on infections was also studied in post-approval studies. Here, investigators collected sputum samples from participants before the initiation of ETI and repeatedly over years. And what they found was an impressive 2 to 3 log reduction in Pseudomonas aeruginosa infection within the first month of use. And this reduction was maintained for the years of the study, with up to 30% of participants having negative cultures. This was also seen in other CF pathogens that the investigators researched. However, majority of people in this study remain positively infected with Pseudomonas, as represented by these gray lines and dots above the red line mean. And looking more closely at those persistently infected, we see only a modest decrease in sputum density of Pseudomonas. And while this reduction was maintained throughout the course of the study below baseline infection rate, there is a slight uptick approaching year 5. Now, from this preliminary data, it's impossible to know whether this is true, if this is a true indication of a rebound infection, as was seen in the ivacaftor post-approval trials, or if this is just variability. But this will need to be monitored over time. Pradeep Singh's group here in Seattle looked further into chronic Pseudomonas infection in cystic fibrosis airways. His team performed bronchoscopy in 9 participants with CF before ETI use and 1.5 years later. Using sterile bronchoscopic technique, they sampled 5 separate areas of the lung, some of more diseased segments and others of healthier airways. And they measured the lavage fluid for many markers, but including Pseudomonas infection. And what they found, to the left on this graph, are the 3 participants who cleared Pseudomonas from their lavage fluid after use of ETI, cleared it in all 5 segments. And the remaining 6 participants, who were still positive for Pseudomonas in cultures, were infected throughout their lungs, finding that persistent infection was not isolated to individual segments or only severely diseased segments, concluding that clearance of Pseudomonas is all or none. Now, Pseudomonas, once it establishes itself in an airway, can become very resistant to clearance. But does it matter to be chronically infected with Pseudomonas in the post-ETI era or not? The answer is that it may, because with persistent infection, there is chronic inflammation. Also from the lavage fluid, the researchers measured neutrophil elastase, which is a byproduct of neutrophil inflammation in the lungs. And in the left column on this figure, in the participants who cleared Pseudomonas infection, they had undetectable neutrophil elastase in their airways. And those on the right who were persistently infected still had elevated levels of this marker. And it is well known that neutrophil elastase predicts future lung function decline. So this creates opportunity and a need to advance therapies to address this chronic inflammation and infection with people with chronic lung disease. Researchers also looked at non-tuberculous mycobacterial infections, or NTM infections, in CF lungs before ETI use and afterwards. And on this colorful graph, you see a large decrease in amount of positive cultures, with the mean going from 40% positivity before modulator use down to 19% on follow-up. Though, as with the Pseudomonas research, some participants remained infected with NTM, and there are even some who became more positive over time. And the clinical impact of this is unknown, and how many of these individuals will need to be treated. This study is ongoing, and we hope to learn more from it in the future. Let's move on to the CF pancreas. With the advent of modulators, I think there was much hope and enthusiasm that they would help dysglycemia and CF-related diabetes. However, in the 30 months of follow-up from the PROMISE endocrine trial, there was only modest changes, with some amount of decrease in fasting glucose, hemoglobin A1C, predominantly in the non-insulin using participants, and no change in glucose tolerance testing results. A recent publication of a prospective study of ETI use in a narrower population of impaired glucose tolerance, or those diagnosed with CF-related diabetes within the previous 5 years, had similar findings of lower glucose, lower A1C, and some improvement in blood glucose levels on repeated glucose tolerance measurements. Now, there can be many explanations of why the CF endocrine pancreas is difficult to affect. There is limited expression of CFTR in beta cells in the pancreas. And in addition, the exocrine pancreas, which we know is damaged from birth, is a poor environment for the endocrine pancreas to function. So as of now, CF-related diabetes will still continue to be a lifelong complication for some individuals. But how about the exocrine pancreas? Can modulators affect the function on the other side? 85% of people with CF are pancreatic insufficient from birth. There are various ways to measure levels of pancreatic exocrine function, but commonly used is fecal elastase in the stool. And from short-term follow-up studies through the PROMISE GI study team, we see that adolescents and adults do not regain pancreatic exocrine function after years of ETI use. But we've learned more from the ivacaftor use in younger and younger ages. And this figure here in the dark blue circles, with initiation of ivacaftor at younger and younger ages, we see an improvement in measurements of fecal elastase levels. A similar pattern was seen in the second-generation modulators of lumacaftor ivacaftor, and the BEGIN study group recently presented their preliminary data showing also a positive increase in fecal elastase in preschool-age children with the use of ETI. And this table illustrates a little bit more. So while these numbers are very small, they are very promising. Looking at the first column of ivacaftor initiated at younger and younger ages, we see restoration of pancreatic sufficiency from 25% in the 2 to 5 year range down to almost 80% when started in earlier infancy. Again, similarly seen with the lumacaftor-ivacaftor trials, and the BEGIN preliminary data also reported that 8% of preschool-age children regain pancreatic sufficiency after 6 months of ETI use. So we are looking forward, with ETI being brought forth to younger and younger ages, will improve exocrine pancreatic function for more infants and children. And this will mean better nutritional status, better growth, and better long-term health outcomes. The Cystic Fibrosis Foundation performed a long-term strategic plan survey, and they queried 900 adults with CF, asking them about the gastrointestinal impacts of CF on their quality of life. And digestive symptom complaints ranked highest, with 77% reporting these symptoms as somewhat or very burdensome. But in the short-term follow-up with Promise GI after ETI approval, with patient-reported outcomes of nausea, bloating, abdominal pain, and constipation, there was very minimal improvement. A separate survey also asked about priorities for ongoing research and care among people with CF, and CF liver disease ranked highest among GI-related concerns. Over 20% of people with CF will develop CF-related liver disease, and over 5% will develop more advanced disease. But also in short-term post-approval follow-ups, there seems to be little impact on function or health of the CF liver. But a recent study presented at a European Conference for Liver Disease in Europe this year, out of a study group in France, provides some intriguing results. This was a nationwide population-based study of over 10,000 people with CF, ages 12 and higher. The investigators collected hospital discharge data and looked for diagnoses reporting outcomes associated with progression of CF liver disease, specifically cirrhosis, variceal bleeding, liver transplant, and liver failure. And it measured these diagnosis codes before the approval of ETI in Europe and the years after. The before was the darker blue lines, and then the ETI era is the lighter blue in the bottom. And they calculated that there was over 70% lower incidence rate of CF liver disease progression in the post-ETI era. So this population study does not provide any information on individual treatments, nor does it prove any causality. But it certainly provides some suggestion that there could be a temporal association with ETI use and progression of liver disease over many years of time. And we hope to learn more about this with ongoing research in this area. Now, these investigators also noted that there was no reports of acute liver injury in their study. But we do know that use of highly effective modulators does put people at risk for liver toxicity. Upwards of 10% of people with CF in the clinical trials did have increases in transaminases, which are markers of liver inflammation, with use of ETI. The majority, these numbers resolved and did not need drug discontinuation. In post-approval FDA adverse event reporting, about 2% of people developed drug-induced liver injury from highly effective modulators. To mitigate this risk, we just really need close surveillance with use. The retrial study group will also be looking at people with CF who discontinued ETI due to liver toxicity and initiating BTD or a lift track and monitoring their health outcomes with regards to the liver. The prevalence of mental health disorders in people with CF is an unfortunate long-standing reality. The CF patient registry has consistently reported increasing rates of depression and anxiety among people with CF as they age. Chronic illness and the significant global stressors of the past 5 years can certainly contribute to issues with sleep disturbances, attention and concentration deficits, and mood dysregulation. We know that CFTR is present in the central and peripheral nervous system, and it can serve many roles. But this is generally poorly understood, and even more poorly understood is if CFTR modulators can affect either positively or negatively any of these impacts, any of these outcomes. The largest publication to date was published last year, looking at relationship with ETI use and rate of depression-related events. These investigators looked at data from over 60,000 people with CF, from national registries in the US and Germany, peer-reviewed survey data, and clinical trial data. And they found that with use of ETI, there was no increase of depression-related events with ETI use. Nevertheless, this population data is reassuring, we know that additional work is needed to better characterize concerns raised by individuals to determine any causative factors. The Prioritizing Research in Mental Health, or the PRIME working group, has identified key research gaps to pursue, specifically mental health in youth with CF, looking beyond the standard depression and screening tools that we use in clinics, and designs a prospective study. The retrial group, in addition to looking at liver outcomes after changing modulators, will also be monitoring people who discontinued ETI for concerns of neurocognitive side effects and looking for their mental health outcomes after starting VTD. Another area with unanswered questions in modulator use is drug dosing and drug exposure. Specifically, who are the best or worst responders to highly effective modulator therapy? We know that people with CF metabolize medications differently, and certain comorbidities or concomitant medications can affect drug disposition. Secondly, how do we manage those who do suffer side effects or toxicities? Can we adjust their dosing and still hope for clinical efficacy? There are individual reports and publications that reduced dosing for certain neurocognitive side effects or liver toxicity does not seem to impact clinical benefit, as measured by sustained reductions in sweat chloride levels and sustained improvements in FEV1 despite lower doses of ETI. Researchers at International Jewish are trying to answer this very question. They enrolled participants on either full dose ETI or modified dose ETI, with the dosing chosen at the discretion of the patients and the clinicians. And using high performance liquid chromatography, they measured serum levels of the various components of ETI, elexacaftor, tezacaftor, and ivacaftor. And what we can see in the modified dosing group, which is the right column in each figure, the vast majority, over 75% of this group, fell above EC50. And above EC50 is where a drug is considered to be still clinically efficacious. In addition, in the full dosing group, despite everyone taking the same full dose of ETI, there was a wide range of drug levels, as you can see, in all the components, with even some individuals falling above Cmax, the maximal concentration of a drug, and some people falling below EC50. Now, this wide range of drug levels could possibly explain the variable response that we see to modulators, and perhaps could even provide information on those with side effects or toxicities. I encourage you to attend workshop 25, where these investigators will be presenting their work more in depth. New frontiers in ETI now brings us to the perinatal period for pregnant women with CF. The well-known Mayflowers trial, after years of work, is coming to a conclusion. The investigators have enrolled 312 mothers with CF, and they have information on 303 live births. Their preliminary data shows that 86% of women with CF take modulators during pregnancy, either for the full duration or at least for partial, and majority are on ETI. Preliminarily, they mentioned that there was minimal modulator discontinuations, and pregnancy complications are similar to background risks, except for gestational diabetes, which we know our patients are at risk for. We look forward to hearing more as they finalize their analyses and present next year. So can the boundaries of ETI use be pushed further and further back into the prenatal time period, specifically using ETI in fetuses with CF? Now, the impact of CFTR function begins before birth, with neutrophilic inflammation in the lungs in newborns, exocrine pancreas destruction, dehydrated intestinal contents leading to bowel obstruction or meconium ileus at birth, and defective embryologic development of the male vas deferens, leaving most males with CF unable to conceive naturally. So this raises the question, can meconium ileus be rescued with modulator use in utero? And can intervening early prevent other organ damage, specifically in the pancreas and in the male reproductive tract? Data from animal models shows us this may be possible. Investigators provided in utero ivacaftor and showed that it did reduce meconium ileus in the CF ferret. 80% of CF ferret newborns have meconium ileus, and it is almost universally fatal. But here on the graph on the right, when these ferrets were provided ivacaftor in the G551D homozygous animals, they had almost near 100% passing of meconium and had normal bowel at birth. In the middle section, the animals that had one copy of G551D showed partial rescue with ivacaftor use in utero. And in the knockout animals who had no modulator responsive CF mutation, there was no difference. In utero ivacaftor use also preserved CF animal pancreas in the male vas deferens. This was research in CF ferrets and CF pigs, also with G551D mutation. On these histologic displays here, you see in the G551D animals treated with ivacaftor, there was preserved pancreatic architecture and pancreatic sufficiency in the newborns, as opposed to the very scarred and damaged pancreas in the middle column of the untreated animals. And we saw similarly that in the treated animals with ivacaftor, both in the ferrets and the pigs, there was preservation of the male vas deferens. Now, data is limited in humans, of course, due to the very complicated nature of this research. Previously, case reports only were available showing that there was some positive response with meconium ileus rescue and even some organ function improvements. But this year, there was a publication on real-world fetal therapy in the Module CF trial out of researchers in France. They treated 12 pregnancies that had a human fetus with modulator-eligible CF, and majority were eligible for ETI. In the 8 pregnancies that had meconium ileus seen on prenatal ultrasound, 6 of 8 had resolution, and at least one of these didn't take the ETI as was intended. And in the remaining 4 pregnancies, they proceeded normally and had a healthy birth. The investigator also noted that there was no abnormal liver tests or cataracts in the newborns, but also that providing ETI at later stage pregnancy at 28 to 36 weeks, it did not prevent pancreatic insufficiency or male infertility. The PROTECT working group is working to advance this field. The prenatal modulator treatment to prevent CF complications, their leadership convened embryologists, geneticists, representatives from the FDA, CF researchers and clinicians to discuss in utero therapy, specifically discussing awareness and understanding of this, how to standardize processes for maternal, fetal, and newborn monitoring, and discussing future clinical trial considerations and design. Please refer to Symposium 12 at this meeting for more on their work. So as I conclude and pass this plenary to my colleague, Dr. Mall, I'd just like to highlight the ongoing challenges with CF therapies. And Dr. Mall will discuss more about advancing research and how we're trying to meet some of these unmet needs. I hope I've shown you today that modulator therapy benefits many, but not everyone, and not completely, both in the pulmonary system and in other organs. There are those that have a suboptimal clinical response. And perhaps bringing ETI and VTD earlier to younger and younger ages, we can improve some of these short and long-term health outcomes. And there is work being done to further CFTR restoration, hoping that it will yield a bigger clinical impact. There is a need to address ineligible populations. And for some, in vitro analyses and broadening approvals will bring therapy to more of the population. But there remain those who will never be eligible for the current modulators that are available. So there is a need to further therapy for nonsense mutations. And finally, I've shown you that there is persistent infection and inflammation in people with CF with established lung disease. Advancing therapeutics in this area are needed to prevent progression and improve long-term health outcomes. So with that, I thank you very much, and I invite my colleague, Dr. Mall, to the podium.
Thank you, Claire. So after Dr. Keating's review of the breakthrough and the remaining challenges in clinical care we have observed with highly effective modulator therapy over the past 6 years, I now want to focus on the new boundaries that we still have to push to restore CFTR function and achieve optimal benefits for all people with CF. Here are my disclosures. And I want to start by taking a closer look at the important concept of continuous expansion of modulator therapy from the F508del mutation to rare non-F508del variants. And the importance of this is shown by this map of the worldwide distribution of the F508del mutation. On average, about 85% of people with CF
have at least one F508del allele, which was required to be eligible when ETI was first approved. However, in countries of Latin America, Southern Europe, and the Middle East, this percentage is much lower, meaning that many living in or coming from these countries could not benefit. And here you can see the common F508del mutation indicated by the blue circle located in the CFTR chloride channel, and where the modulators, elexacaftor, tezacaftor, and ivacaftor, indicated in green, blue, and orange, bind to CFTR. And a completely unexpected and important discovery that enabled the expansion of ETI therapy to people with non-F508del variants in the US was that not only F508del, but many rare variants distributed throughout the CFTR chloride channel that are shown here in turquoise respond to this therapy when tested in fissurate thyroid or FRT cells in vitro. So to date, over 600 rare variants have been tested in this system, and over 80% were found to respond to ETI, and over 30 more variants were already found to respond to the new triple combination of VTD. Importantly, this responsiveness of rare variants to modulator therapy in FRT cells translates into clinical benefits, where, and this is shown here by this controlled trial, where you can see improvements in important clinical outcomes, including lung function, sweat chloride, and quality of life in people with non-F508del variants that were comparable to the improvements that were shown in previous clinical trials in people with the F508del mutation. Now, importantly, similar observations were also made in the French compassionate use program in people with CF without an F508del mutation, including many variants that were not approved for ETI by the FDA. This program used a 4 to 6 week trial of therapy and found that overall more than 60% of rare non-F508del variants responded clinically to ETI, again, as determined from improvements in lung function, sweat chloride, and other clinical outcomes in the real-world setting. So collectively, these data have led to a continuous expansion of regulatory approval from at least one F508del mutation in 2019 to many additional variants. In the US, this was supported by the in vitro data in FRT cells, with the first expansion occurring already in 2020, and further expansions of ETI, and with the approval of VTD end of last year. In Europe, this took much longer, but based on the results of the rare mutations trial and the French compassionate use program, ETI and VTD have been approved earlier this year for all people with at least one non-class 1 mutation, meaning all mutations that can make protein. With the important result that now approximately 95% of all people with CF are eligible for highly effective modulator therapy in the US and in Europe. And I think this is really a major achievement since the first approval of ETI. A key question that has emerged from this data is how modulators can restore function to so many different CFTR variants. So you know that modulators were developed based on high throughput screening and shown to restore chloride channel function to the common F508del mutation that is located in the nucleotide binding fold 1 or NBD1 of CFTR. However, for a long time, we did not know where exactly the modulators bind and how they work at the molecular level. And with a recent breakthrough in visualizing CFTR structure at very high resolution using cryo-electron microscopy, you can see here on the slide, it has become clear that the correctors elexacaftor and tezacaftor do not bind to MBD1 directly, but to distinct sites in the transmembrane domains of CFTR, and through this binding cause a conformational change that corrects the destabilizing effect of the F508del mutation in the protein, a phenomenon that we call allosteric stabilization. And the functional studies in FRT cells show that this allosteric stabilization can not only rescue F508del, but many other variants throughout the CFTR protein. This is not only important for CF therapy, but really a novel mechanism of action allowing the treatment of multiple disease-causing variants with a single drug that may also be applicable to many other rare genetic diseases with a high unmet need. Next, I want to focus on ongoing efforts to further enhance the efficacy of modulators, aiming for full restoration of CFTR function for optimal clinical benefits. So the rationale for this is based on studies of biomarkers of CFTR function, such as sweat chlorides, and as you can see here, nasal potential difference and intestinal currents, showing that restoration of CFTR function by current modulators remains incomplete. As you can see from this data, ETI restores CFTR function in the airways and intestine in people with at least one F508del allele to around 50% of healthy levels. From natural history studies, we know that variants with residual function in this range still cause CF, and that healthy carriers have 80 to 90% of normal CFTR function. So collectively, this data supports that further enhancement of CFTR function is important. This notion is also supported by emerging data reviewed by Dr. Keating, showing that the magnitude of restoration of CFTR function by modulator therapy, as shown here for sweat chloride and intestinal current measurements, correlate with improvement in lung function and other clinical outcomes. An important step in this direction is the recent approval of the second generation triple combination therapy of VTD that was shown to further improve sweat chloride on top of ETI and thereby further increase the percentage of patients with a sweat chloride concentration below 60 millimole per liter and below 30 millimole per liter, so that now more than 90% of children that were included in the pediatric trial reach borderline sweat chloride levels, and more than half reach normal sweat chloride levels on VTD therapy. And while VTD has just become available to patients in the US and Europe this year, another big step has already been achieved in the Vertex laboratory with the development of a next generation corrector, VX828, that in dual or triple combination is substantially more effective than ETI and VTD and achieves normal levels of CFTR function in studies of CF, bronchial airway epithelial cells expressing F508del in combination with a minimal function mutation. These exciting results support that it is possible to achieve normal CFTR function with modulators, and based on this data, this next generation corrector is now in early clinical development. So, as mentioned earlier, all these correctors bind to the transmembrane domains of CFTR, whereas these old data shown here suggest that rescue of F508del function may also be possible by direct targeting of MBD1. So this was actually shown over 30 years ago by introducing so-called revertant mutations, R553M and R553Q, into MBD1. And in this assay, shown on this slide, where upward deflections of tracings after cyclic AMP-mediated stimulation indicate chloride transport, you can see that these revertant mutations alone have no effect on CFTR-mediated chloride transport, when compared to wild-type CFTR, but that they are able to restore chloride channel function in cells carrying the F508del in combination with a revertant mutation as indicated by the green stars, but not delta F alone as shown here by the red star. So based on this observation and the important role of F508del in destabilization of MBD1, which prevents normal CFTR folding, trafficking, and function, and as none of the current modulators acts on MBD1 directly, Sionna is working on compounds that directly bind and stabilize MBD1, shown here as Cyan 719 and Cyan 451 as a new mechanism of action for F508del correction. And I'm happy I can share the preclinical data from this program supporting that pharmacological stabilization of MBD1 can help to normalize delta F508 maturation and function, which is shown here by profound effects of Cyan 451 on the well-known thermal instability of F508del MBD1, as shown by the shift in the melting curve to the right, as well as expression of full-length CFTR in F508del expressing cells by the MBD1 stabilizer alone that is increased to wild-type levels in combination with Sionna's domain assembly modulators that bind outside of MBD1, as well as in combination with ETI. And importantly, improvements in F508del chloride channel function in CF bronchial epithelial cells, where the stabilizer alone showed rescue of CFTR function comparable to ETI, which is further improved to wild-type levels in dual combination with the domain assembly modulators. So based on these very promising data that again support that full restoration of CFTR function to normal levels is possible, MBD1 stabilizers are now in clinical development, with the first phase 2 testing the effects of the stabilizer on top of ETI as standard of care. Despite these exciting developments, approximately 5% of people with CF cannot benefit from modulators today based on their genotype, and most people in this group carry at least one nonsense or class 1 mutation, and I therefore now want to touch on where we stand with novel strategies for pharmacological restoration or correction of this important class of mutations. The key issue with nonsense mutations is that they lead to a premature termination codon in the mRNA that causes a stop in translational read-through at the ribosome, leading to a truncated protein that does not function. When we now zoom in on the molecular mechanism of premature termination, you can see that certain release factors, ERF1 and ER3, play a key role in recognizing the premature stop codon and releasing the immature protein from the ribosome, thus leading to early termination of translation. On the other hand, near cognate tRNAs can bind to these stop codons with low affinity and facilitate translational read-through. So a key issue here is how the balance can be tipped from premature termination of translation to read-through so that a functional protein can be made. And here, as an example, you can see recent data obtained by a collaborative team involving UAB, Southern Research, and the CFF Lab with a small molecule degrader of the ERF3 release factor that has been identified by high throughput screening and does not belong to the family of aminoglycosides that have previously failed in clinical development. So this release factor degrader can restore CFTR function in CF airway epithelial cells carrying different stop mutations to about 5% of wild-type CFTR. And of note, this rescue can be further increased in combination with a degrader enhancer. So we are seeing another evolving concept of combination therapy. And several complementary approaches are currently under investigation to tackle the complex problem of nonsense mutations, including small molecule-mediated readthrough, readthrough with engineered tRNAs, small nucleolar or SNO RNAs that can mediate readthrough by modification of the stop codon, and antisense oligonucleotide-mediated RNA editing. Based on these active research programs, we will now hopefully also see successful clinical development of effective pharmacological strategies for nonsense mutations in the near future. In the final part of my talk, I want to address the remaining need for novel strategies to improve mucociliary clearance and reduce inflammation and infection. This is for two reasons. First, novel drugs that improve mucus clearance, inflammation, and infection more effectively than what we currently have remain critical for people with CF who cannot be treated with modulators. And second, as mentioned before by Dr. Keating, we have learned from real-world observational studies around the world that these characteristic changes in the CF lung improve substantially, but the bronchiectasis as well as residual mucus dysfunction, inflammation, and infection persist on modulator therapy, probably at levels similar to non-CF bronchiectasis. What has also become clear in this context is that airway damage and dysfunction in bronchiectasis can maintain a vicious vortex of mucus hypersecretion, chronic infection, and neutrophilic inflammation, even in the absence of CFTR dysfunction. And I want to present two strategies now that target different components of this vicious vortex and are currently tested in clinical trials. First, inhibition of the epithelial sodium channel ENaC to improve mucociliary clearance, and second, inhibition of dipeptidyl peptidase 1, or DPP1, to reduce inflammation. So, as many of you know, ENaC has long been considered as an alternative therapeutic target in CF, as this channel is a key pathway for salt and water absorption from airway surfaces that plays an important role in mucus dehydration and impaired mucociliary clearance when CFTR-mediated fluid secretion is impaired. However, previous ENaC blockers failed in clinical trials, probably due to limited duration of action and/or systemic side effects. To overcome these hurdles, Enterprise Therapeutics has developed a novel, long-acting inhaled ENaC blocker, ETD-0001, that promotes mucus hydration and effectively improves mucociliary clearance in the sheep model for up to 18 hours after a single inhalation. As this mechanism of action is independent of CFTR mutations, it also has the potential to work for all people with CF. And based on a favorable safety profile in healthy volunteers, this ENaC blocker is currently tested in a phase 2 trial in Europe in people with CF who are not eligible for modulators, and this trial is fully enrolled now with results expected early next year. We have also known for a long time that increased activity of neutrophil elastase, or NE, secreted by neutrophils that are recruited into the airways, play an important role in the pathogenesis and progression of CF lung disease. Neutrophils also secrete two other serine proteases called cathepsin G and proteinase 3, and together these proteases cause damage of the bronchial walls leading to bronchiectasis, but also contribute to mucus hypersecretion, impaired ion transport, neutrophilic inflammation, and impaired pathogen clearance. And as you can see here, all of these three proteases are activated by the same enzyme called DPP1. So this led to the development of selective DPP1 inhibitors that control the excess activity of all three neutrophil serine proteases without impeding other important neutrophil functions to slow disease progression and improve host defense and homeostasis in chronically damaged airways. So far, DPP-1 inhibitors have been primarily developed for non-CF bronchiectasis, where they were shown to reduce pulmonary exacerbations in several trials now. However, when one of these compounds, verducatab, was recently also tested in a phase 2 study in people with CF with a similar symptom burden, it was found that the baseline activity of NE in sputum was comparable between CF and non-CF bronchiectasis, and that the inhibition of neutrophil elastase activity in the sputum that was in the range of 90% relative to baseline during the duration of the CF trial was also comparable with previous results in non-CF bronchiectasis. So based on these similarities, the ongoing activity study of verducatab for the first time includes people with CF with bronchiectasis together with people with non-CF bronchiectasis in a single large global phase 3 trial to test the clinical effectiveness of DPP-1 inhibition as a novel anti-inflammatory strategy for up to 76 weeks in both diseases, irrespective of bronchiectasis etiology. And I think this trial is really important as it introduces a new one bronchiectasis concept for clinical drug development that could really facilitate and speed up the development, not only for anti-inflammatories, but also for novel mucolytics and anti-infectives, both for CF and for non-CF bronchiectasis. I want to conclude by looking at the CF drug development pipeline that summarizes the amazing therapeutic breakthroughs we have seen so far, especially with 5 therapies that restore the underlying defect in the CFTR protein that are already available to patients, and a robust pipeline for even more effective restoration, aiming for normal CFTR function, as well as novel therapeutic strategies for more effective control of mucus clearance, inflammation, and infection that will remain important adjunct therapies for many people with CF. So in summary, the introduction of highly effective modulator therapy in 2019 has really transformed cystic fibrosis, and with the recent label expansions is now available for up to 95% of people with CF. This breakthrough treatment is being brought to younger and younger ages, including potential use in utero, which has the potential of the broadest but also largest lifelong benefit. We are still increasing our understanding of long-term positive impacts, but also the limitations of current therapy, and it's therefore important to see the very promising and exciting research that is underway to restore CFTR function in all people with CF, aiming for healthy levels for optimal benefit. And as many people with CF already have lung damage when modulator therapy is started, and as bronchiectasis persists when CFTR function is restored, novel therapies that tackle mucociliary dysfunction, airway inflammation, and infection remain important and may also provide benefits to people with non-CF bronchiectasis, a disease that has more recently actually emerged as the 3rd most common chronic lung disease worldwide with a high unmet need. So I stop here, and on behalf of Dr. Keating and myself, want to thank all colleagues and pharmaceutical companies who contributed their data and ideas, and all, thank you, and all, also very important, basic and clinical CF researchers, the CFF TDN and other clinical trial networks, CF care teams, people with CF and their families around the world for their continuing efforts that made this amazing progress possible and will be critical for the next steps. And I thank you for your attention.